without further delay, I think we can start about the layers of the face. For this, I will share my screen with you, which will happen right now. So, and here you can see that. We can just jump to the beginning because that was the ending slide. There we go. So, this is the topic, layers of the face. The question is always, why is this important to know the layers of the face? And one of the reasons is because the face is a three-dimensional structure. So that means 3 dimensions, not only 2 dimensions, like in most books where you just have one plane with 2 dimensions, but we have 3 dimensions. And what does 3 dimensions actually mean? It means that there's one layer, and below that there is another layer. So this is important to understand relationship. It's not only important what is here and what is here, it's important what lies below that. And this is what is about the concept and layers of the face. I do not have any disclosure or conflict of interest with the industry because I'm reporting on anatomy, and this is pretty free of any conflict of interest. So the general concept about the layers of the face is that the layers of the face are kind of 3-dimensional structures, but also it's important for the clinical aspect because when you treat one area of the face, you can have an effect of another area of the face. Example, you treat the upper face and then you have an effect on the lower face. Why? Because the layers and the regions are connected by parallel layers. So it's kind of one area is connecting to the other area. And this is kind of the reason why it's important to understand the layers. So if you perform dissections of the face, you can have multiple layers of the face. And the normal, the basic and general arrangement of the face is the 5-layered arrangement. So you start with the skin. This is what you see. But below the skin, you have the superficial fat and the fascia, the superficial fascia, how it's called. And the superficial fascia is called also the smas or the superficial temporal fascia or the platysma. It's just one plane, as you can see here in this picture. And below that, you have the deep fat compartments and a deep fascia. In some instances, you have the deep temporal fascia or the parotidal fascia, just depending on which layer of the face you are. But in total, you have 5 layers of the face. And even sometimes you have deeper layers of the face which travel in very deep areas of the face, but they are kind of not sometimes very tricky to assess and even more tricky to dissect. So when you dissect the whole face and look at the different layers of the whole face, it looks a little bit like this. So you start the dissections from the temple, as you can see here, and you can see how all the layers are connected from the upper face down into the middle face and into the lower face. And now I hope you understand how these areas are connected with each other, because everywhere in the face you have layers. You don't have only layers of the face in the temple or in the mid face. We also have them on the forehead, as you can see here. You can have them only on one side, you can both on both sides. It just depends on where you want to see, but this is important to understand. Layers can be identified in every region of the face, and which is very important for you because you need to know that your treatments are kind of influenced by each other. And also you need to know that in some layers you have specific structures like nerves or like vessels, and they are located in each specific layer. So this is kind of how my dissection looks like. And if you want to see how I did this dissection, you can see that you need a lot of materials to be able to dissect and to perform all of these areas at once. These layers of the face need to be connected to the underlying bone, because layers can glide, yes, but they also need to be connected to the bone. And how do you connect layers of the face to the bone? With ligaments. And I know there are a bunch of different studies who have indicated that there are different types of ligaments, but because it's very complicated and every author tells different things, I would recommend that you just know 4 of the most important ligaments, which I've shown you here. And these 4 ligaments, if you move your layers, these ligaments stay attached to the same location, which means they are true osteocutaneous relationships. And all of these ligaments are arranged in a line, and this line is called the line of ligaments. It's nothing new, but we published 2 years ago on this line of ligaments. And this is important because it separates the face into a medial face and into a lateral face. And here in this area, here you can see the medial face, and here you can see the lateral face, which is very important. And one of the most important aspects is that injections into the lateral face, because of the layers, can influence outcomes in the medial face. And how is this clinically relevant? For this, we did a study with a dear colleague of mine who lives in Spain, and with her name is Gabriela Casabona. And Gabi did a very nice study because she injected the same patients but different left and right. It was a split face study, but what she did between the left and the right side was that she injected the same injection points but a different sequence. On one side of the face, she started to inject first lateral and then medial, and on the other side she injected first medial and then lateral. Kind of just same points, different sequence. And then we looked into the symmetric outcome, because both sides of the face need to look alike, very symmetric. But we compared the amount of volume that you needed to achieve a very similar outcome. And this is the results. It shows that when you inject lateral first, you need less product as compared to when you inject medial first. And the reason is because lateral first, you inject first to the line of ligaments, and that means you tense the tissues. You really inject here, and then you elevate the tissues, and then you need less product here to have the same volumizing effect. What does it mean clinically? Clinically, it means if a patient comes to you and doesn't have a very big budget, or comes to you and says, "Doctor, please change my appearance," then you can say, "Yes, I can do that." And then you start injecting here, and then you go here. And then you will see you have a very nice effect, natural looking, but with less product, because you know exactly that you understand the anatomy, you tense the tissues, and then you need less product here. And this is kind of a very important aspect that you need to consider when you do your treatments. And this is kind of the publication, which was published in June in 2019. So this is why you need to know layers and why you need to know about the line of ligaments. But let's go into a greater detail about layers of the face. And of course, when we speak about layers, it's important that you know about superficial fat compartments. The question is, where are the superficial fat compartments located? So if you look at the different layers of the face, you have layer number 2, which you can see here. It's this area here. And this layer number 2 is the subdermal fat. And the subdermal fat lies on top of the smuts, which you can see here. And we talk about this area here, you have the superficial fat compartments. The superficial fat compartments are very well vascularized, as you can see in this picture, because you can have a lot of vessels into the subdermal plane, which is actually pretty good. And in 2007, the first studies identified an area which was separated from another area, and they started to talk about compartments, which means some compartments that have boundaries, some things that kind of really look very very different from each other. So it was an interesting finding to say, oh, these are the fat compartments. Later on in 2010, another research study kind of confirmed those fat compartments, which was very good actually. And in 2015, our research group confirmed this with CT scanning. Very much with CT scanning, we kind of inject into each compartment contrast agent, then you scan that respective area, and then you identify if the contrast stays there into a respective area. And yes, we were able to identify this. But if you inject color into these respective areas, and if you start to move and look at the mobility of the respective fat compartments, you will find out that some of the fat compartments move more than do other fat compartments. And this is very important because there are some fat compartments who move, especially with gravity and especially with aging, and they contribute to changes of the aging phase. And these changes of the aging phase can be seen in your patient. You can see that. If you move the red one that I just showed you, which is the superficial nasolabial fat compartment, which is this one here, if this fat compartment moves down, you have nasolabial fold. If the blue one that I'm moving now, which is the jaw fat compartment, is moving downwards here, you have jaw's fat compartment. Here you have increased marionette line, you have increased jawline, you lose the jawline contour. All of these things that are age-related, you can see that exactly and based on the respective superficial fat compartments. So this is very important for you to understand that it really happens that the difference in the superficial fat compartments and their mobility and their biomechanics influence the aging process. So if you understand that this is because of the superficial fat compartments, then you know how to better treat your patient. And this is the respective paper published in 2018, as you can see. And it kind of shows very nicely what has been done in the past. And if you go deeper after the superficial fat compartments, we find another structure, which is termed the superficial musculoaponeurotic system. And this superficial musculoaponeurotic system, also termed SMAS, is located below the superficial fat compartments, which is this area here. This area here between the superficial fat compartments in layer number 2 and between the deep fat compartment, which is in layer number 4. You can see that exactly here. The first publication is this one in plastic reconstructive surgery in 1976 by Mitz and Perroni, but they were not the first ones. They were absolutely not the first ones, because the first description of a superficial fascia goes back until Galen, very, very far posteriorly. And they are also not the first ones, because the superficial fascia was described in a face, but there's also superficial fascia in the abdomen, which is called scarpa fascia. And there's another fascia also in the perineum, which is called collis, which is also superficial fascia. So there are different fascias across the whole body, and they have a very important aspect to protect and to provide mobility for the overlying structures. And because in different areas of the body, we can have different arrangement, the SMAS, or what we understand as SMAS, but is actually called the superficial fascia, is just different. And what is very important in the face, the SMAS is important to move the overlying skin. They're kind of all interconnected. But how does it look like? How does it really look like when you do dissections? So this is how it looks like in the scalp. You can see the hair, and here you can see the acronym, which is termed scalp, but which stands for the different layers: skin, connective tissue, aponeurosis, which is the galea aponeurotica, loose connective tissue, and the periosteum. Kind of, when you do dissection, you can kind of see exactly these respective layers. But as I told you before, this can be found anywhere in the body. And is this really true? Yes, it is true, because you can see that here. This is, for instance, in a butt, in a gluteal area. You can see gluteus maximus muscle, and you can see their respective areas, which you can also identify with ultrasound. It's very straightforward how all of these structures are located. And where does it arise? Where does it come from? Well, of course, it comes from embryology. And in embryology, we already have the superficial fascia, which is indicated by the S in these images here. You can already have the superficial fascia in the embryo, because it's important to envelope all of these structures, because you need a structure that connects the muscles of facial expression to the overlying skin. And is this mass just a layer? The answer is no. it's a compound. What do you mean by compound? A compound is a composite of different tissues. If you perform electron microscopic investigations, it looks like this. You have connective tissue fibers and you have fat. They're all enveloped together. It's a three-dimensional vascular network, kind of, that all act together. And the connective tissue fibers are crucial and are very important because these connective tissue fibers provide elasticity and provide firmness and robustness for this mass in the face. And here is an overview how a mass looks like when it's virginal, which indicates when no surgery has performed. And here on the other side, here on this area, you can see how this mass looks like after the second facelift surgery. You can see here it's still very curly, it's like a spring, and here the spring is not very curly anymore, it's pretty straight. You can imagine what this means for the elasticity of these respective areas. So kind of, it's not very elastic anymore, it's just straight, flat. And this is kind of one of the features that can result from aging, but also from, of course, facial surgery, which you can appreciate in these pictures. So I told you before that the SMAS connects the muscles of facial expression to the skin, but how is that possible? Well, for this, we need to look again to the anatomy. When we speak about layers of the face, I told you that we have a specific layers, which is included orbicularis oculi, SMAS, and the platysma. It's kind of just, it's one plane. But there are muscles in the face that originate from the bone, like these muscles here, and they connect more superficially. Kind of like if you have the SMAS here, the muscles come deep and then they travel within the SMAS. This indicates that when you perform aesthetic procedures on the SMAS, you will have an effect of facial expression. And I think everyone who performs facelift surgery knows that when you pull and reposition the SMAS and you do facelift surgery, the facial expression is differently. Sometimes people even complain about hypomimia. Why? Because the muscles that you can see here are already stretched. They're already tensed and they cannot have their mobility anymore. The amplitude of movement is reduced. And this is because you do something to the SMAS, and this is because the anatomy is kind of like this. And there are some other very important implications that you need to understand, that the SMAS is continuous with orbicularis oculi and SMAS is continuous with the platysma. These are all important aspects that you need to understand because it's one layers. You will see in the future, there will be an injection technique to treat the platysma with toxins here in this area, comparable to a Nefertiti lift. And then you will have an effect of the midface and on the upper face. Why? Because they're connected. They all are connected with each other. They're connected because it's layers of the face, which is the topic of today's lecture, to make you understand that the layers of the face are very important. And if we look at the platysma, where is the platysma? Of course, we talked about the different layers so far. We talked about the skin, we talked about the subcutaneous fat, and there you have the platysma. It's layer number 3, and it continues platysma, SMAS, superficial temporal fascia, all of them come together. And is it important for clinical procedures? Yes, it is important because you need to know at what depth you have your platysma and how thick is your superficial fatty layer. And this is one of the publications that we did. And it shows you that with increasing age, which means over time, when you're getting older, you lose subcutaneous fat, which is very interesting because you think with age, there are some papers that said, yeah, you increase volume of the superficial nasolabial fat compartment, or here you increase the volume. No, you don't. You just lose it, because this is what with aging process happens. during the process of aging, we lose volume of the subdermal fat. And this you can see in the different areas. And this happens not only in the buccal area, which is this graph, it also happens in the parotidomesenteric area, which you can see here. And it also happens in the neck, because even in the neck, over time, the subdermal fat is being reduced in thickness, which is important for you when you think, for instance, about radio frequency and high energy based devices, how deep you can go. At higher age, the thickness becomes less and less, which means if you go deeper, you are even deeper because there are the nerves. So again, you need to consider this and individualize your treatments. So we talked about superficial fat, desmas, and let's talk about the deep fat compartments. The deep fat compartments are located in layer number 4, which you can see here. It's lying below desmas. And these fat compartments are separated by muscles. Like here, you can see that, for instance, not only by muscles, but also, for instance, by the angular vein and also by the infraorbital foramen. They're all separated by these respective structures because they are also deep. They're deep structures, and the deep fat compartments are located around these structures. And if you inject contrast agent, you can identify the different compartments, and you can identify that the muscles determine the boundaries of these fat compartments. You can see that here, that this muscle, levator labii superioris alaequinasi, forms a boundary for the deep nasolabial fat compartment, and the levator anguliores also forms a boundary for the deep piriform space. So all of these structures they form boundaries with each other. And additionally, you can also very precisely see that here you have the infraorbital foramen, which forms the lateral boundary of this space. So it's very important to know, especially when you treat the piriform fossa with deep injections, you inject actually in the deep piriform space, because it's a bounded compartment where you have exactly those structures located. And if you want to have an overview of all of the fat compartments, they can be found here in this instance. So you have the orbicularis retaining ligament, you have the zygomatic cutaneous ligament, you have zygomaticus major muscle, the angular vein, and the infraorbital foramen. These are very constant structures in the face, and around them and deep, you have your deep fat compartments, like the medial suve, the lateral suve, the deep lateral cheek fat, the deep medial cheek fat, and the deep piriform space. So you have all of these compartments located around the structures, and you can imagine that these structures are very important and very stable in the face. But let's think about what it means for the process of aging. During the process of aging, are these fat compartments changing their position? And the answer is no, they don't. These fat compartments are stable, very, very stable fat compartments. They do not change their position because their boundaries are also stable. The infraorbital foramen stays there. Muscle origin, like levator labii or levator anguliores, they stay stable. So when they stay stable, the fat compartments also stay stable, which is very important. And this means clinically for you, when you inject into the face and you want to have a nice foundation, you want to increase the fundament, you want to increase the projection, you need to inject deep into this area. When you inject deep, you inject in contact with the bone, you inject into the deep facial fat compartments. And these fat compartments are encapsulating your product, and this will give you a very nice increase in the fundament. You can create the fundament by doing so. And this is important for you to understand how this is possible, because it will determine how you treat your patients. So when your patient has volume loss, of course you're injecting deep, because you're injecting deep in contact with the bone into the deep fat compartments. You do not inject superficially, because you remember and you know that the superficial fat compartments, they change and they are mobile at higher age. So this is important because it really reflects, and anatomy can guide your treatment options if you understand the anatomy. Of course, you can say, I always injected deep. Yeah, that's good. You did a good job. But here in this paper, you have the explanation why this is the case. So I think this is important for you to understand. So if we think about all of these aspects, I think it's important that we also focus on specific areas of the face where we better understand the layers of the face. And one of these areas, which I think is very important, is actually the temples. The temples is a very important area to understand the layers because it determines where you inject. So you have different layers in the temple. Like here you have your skin, then you have your superficial temporal fascia, which is this plane that you can see here. And then below the superficial temporal fascia, you have your deep temporal fascia, which is this one here. And after the deep temporal fascia, when you remove that, you have some fat compartments. You have the superficial temporal fat pad, which is this one. And then you also have your deep temporal fat pad, which is this other one here. That orange one, that's the deep temporal fat pad. And then of course you have your temporalis muscle, which is lying in contact with the bone and which needs to be respected because within the temporalis muscle you also have some vessels as it overlies the periosteum. And here you can see the two vessels, the anterior and the posterior deep temporal artery. So now we understand that the temples has different layers. How does it reflect clinically? So I can tell you how this clinically reflects. You have different injection techniques. You have, for instance, a subdermal volumizing injection technique with a cannula. You can see that here. You inject into the temple and you position your product into this area. You can see that here very nicely. This is how you inject to volumize the anterior temple. But you can also inject into the temple to increase jawline contouring and to elevate the mid-face and the lower face. So you inject a bolus injection here, high into the temple, and then you elevate all of the tissues and which increases the jawline contour. We published on this multiple papers, and I really encourage you to try this technique. It really works very, very nicely. You will use a 22 gauge cannula, 50 or even 70 millimeters, and inject a bolus of high G prime product. The bolus is around 0.7 to 1 cc of product, which is quite a lot. You inject the bolus high up here. You might ask, will the patient not see that? No, because it's behind the hairline. And behind the hairline, no one really cares about. So this is a lifting technique for the temple. Lifting technique for the temple. And then you have another technique to volumize the temple, which is called the interfacial injection technique. You can see that here. Interfacial injection technique, you enter from the forehead in contact with the periosteum, and you position your product between the superficial temporal fascia and the deep temporal fascia. There you can see that how the cannula is located on top of the deep temporal fascia. So it's a very nice technique because it's independent of the product. You will not see the product on the surface. You just glide between the two layers very nicely, coming from the forehead and going into the temple. You can see that here very nicely. This is how you position your product. Again, 22 gauge cannula, 50 millimeters, access from the temple in contact with the bone, and then you glide very directly and straightforward into the temple. So this is the interfacial injection technique. And the last injection technique, I think all of you know very well. This is the injection in contact with the bone. You go one up and one over, and then you inject in contact with the bone. The needle is in constant contact with the bone surface. You position it here, and you can see that here very nicely how you can put your product here straightforward. I think every one of you knows this technique. Most of you do this technique, but this is kind of to show you that you need to pass all of the layers. And again, talking about layers, how you can position your product in this area. Another area which I think is also very important to understand the layers is the tear trough. Because the tear trough, most people are afraid of the tear trough, and I do agree that it's a tricky area, but the only reason why the tear trough is so difficult is because it's unforgiving. The tear trough does not forgive you if you make a mistake. This is why a lot of injectors are afraid of the tear trough, because you can see immediately your outcome. And this is a tricky thing about the tear trough. But let's review first the anatomy of the tear trough. When you remove the skin, you can kind of see this area. This area corresponds to the differences in orbicularis muscle and also corresponds somehow in the young individual to the inferior orbital rim. Above this line, in the area of the tear trough and in the area of the lower eyelid, you have no subcutaneous fat. You have no subcutaneous fat. And you can see that here again, because if you focus here on my mouse, in this area here, you also have no subcutaneous fat in this area. And it also gives rise to the difference between the malar and the nasolabial fat compartment, and also gives rise to the V-frame deformity. You can see that here. This is termed the V-frame deformity. And again, these are superficial fat compartments which lie on top of orbicularis oculi muscle. And if we elevate orbicularis oculi muscle, which I did here in this dissection, in this area here, we can expose some other fat compartments. We can expose the roof and we can expose the SOOF. These are all fat compartments are located in this respective area below the orbicularis oculi muscle. But there is one thing you need to be aware of, which is the medial boundary of the SOOF. If you look at this picture, you have orbicularis, you have superficial nasolabial, and you can see in which layer they are, and you have the SOOF. And you have, of course, the angular vein. So for you, it is most important to understand that the SOOF ends here. The SOOF ends exactly here. And here you have bare bone. You have no deep fat, which means for you that in the tear trough, you have no subcutaneous fat and you have no deep fat, which is important because this is where you position your product. You position your product exactly into this area here. Right here, there goes your product. And I think for you, you need to understand this because the product goes between the different areas of ligaments. Here you have your orbicularis retaining ligament, and here you have your angular vein, and here in between there is your tear trough, and there you can position your product. And this is for you most important to understand that in this area you have no superficial fat, no deep fat, and this is why you need to inject deep. There is no artery, and the vein is out of the way. So this is important, very important. When you treat the tear trough, you need to know what the boundaries are. To access the tear trough, you can either access from here and move all the way over, or you can access from here and move along this pathway to reach the tear trough in this area. If you're afraid of the vein, we published in 2017 a paper where we kind of showed that the distance from the inferior orbital rim to the angular vein is 4 millimeters. And in soon future investigations, you will see that the angular vein also is above the tear trough because the angular vein dives into the orbicularis oculi muscle. So these are all important aspects and which will be also future studies and future research. So we talked so far about the layers. Remember, layers kind of all are parallel in the face, but there are exceptions. And these exceptions are a couple of them. And I will present some of these exceptions to you. Exception number one is transverse facial septum. It's a new structure in the face, and this new structure in the face, which is termed the transverse facial septum, forms the inferior boundary of the deep midfacial fat compartment. And this septum is in relationship to zygomaticus major muscle. You can see that here very nicely. Here you can see this area here. This is here the transverse facial septum below zygomaticus major muscle, and here you have this area here. This is the area where you have your deep midfacial fat compartments. So what happens when we smile? So when we do not smile, zygomaticus major muscle is very relaxed. When we smile, zygomaticus major muscle is tensed. Here, the transverse facial septum is relaxed. Here, the transverse facial septum is tensed, under tension. And this indicates that when you smile, so when you go from here to here, you push the deep midfacial fat compartments cranially, which is indicated by the vectors that you can see here. And you can see that clinically as well, because you get apple cheeks, you get increase in volume when you smile. Children have this very frequently. When they smile, it really looks like cute little apple cheeks. Why is this important for you? Because you need to understand the facial overfilled syndrome. A lot of people injecting the midface with too much volume. The problem with that is that the patients look very nicely at rest. They look very nicely when someone is at rest with the amount of volume. But when they smile, the transverse facial septum has an effect. It pushes fat compartments up, and it also pushes the filler material upwards, which means at some point there is too much volume. You just need to think about the fact that at rest there is enough volume. When you smile, because all of the fat compartments are being pushed upwards, there is too much volume. And this is important to understand. When you treat your patients, what you need to do is dynamic filling. So it means you inject your patients and then you ask your patient to smile. And if there's enough volume, just stop. Don't do more, because it's important, because you do not want to have a facial overfilled syndrome. This is very, very important for you to understand. And it's an exception to the layers of the face. The second exception is the nasolabial sulcus. We talked previously that we have skin, subcutaneous fat, mass, deep fat, and then the deep fascia, kind of the parallel layers of the face. At the nasolabial sulcus, this is differently. At the nasolabial sulcus, the muscles of facial expression, they insert into the skin. Originally, the muscles of facial expression, they come from the bone. As you can see here, muscles of facial expression are three-dimensional deep structures, really deep three-dimensional structures. And histological analyses have shown that the muscles insert into the skin, which means that they form a natural boundary for the superficial overlying fat compartments, which is crucial, because the superficial fat compartments, they cannot descend. They cannot, because there's a hard stop, there's a hard boundary. And because they cannot do that, you prolapse. You see that here. You have an increased nasolabial fold when I do that. When I do this, it looks nice. When I do this, it looks aging. And this is just because muscles of facial expression connect to that respective area. And you can see that here, in this area here, you can see that very nicely, because the muscles, they become more superficially. And by the arrows, it is indicated that you have the connection starting from the nasolabial fold, which goes down and across the marionette line and actually even continues into the submental sulcus. It's kind of really a line where you have the perioral muscular block. And if you perform dissections in this area, you will see it's very tricky to dissect because muscles and skin are very, very tight in this area. And this is why it's always a little bit tricky to show how all of these structures are connected. When you do CT scans, you can see also these respective areas, which I just discussed to you. Here you have your nasolabial sulcus. Here you have your labiomandibular sulcus, which is the marionette line, and then you have your submental sulcus. These structures can be very nicely identified and individualized here in this respective area, which is actually great to understand because then you know how to treat them. You know how to treat this area. If we now continue and remove the skin, you can see that there are muscles which are coming more superficial here and here, which at some point overlie the bone and which you can see. Which brings us to another topic because we talked about the nasolabial. We know how to treat the nasolabial, which means we inject into this area to straighten out the nasolabial fold. I know a lot of people would like to inject the nasolabial fold by injecting into this line. Don't do this. Just don't. There are a lot of other treatment options where you can inject up here and up here, but here in this area, just don't, because otherwise you increase the volume here and you make your patient look like a monkey. You don't want to do that. And what about the marionette line? In the marionette line, you have different options. In the marionette line, you can inject at the angle of the mandible, which is here in this area, deep in contact with the bone. You can do that very nicely. And then you can tense and pull traction on the tissues. But if you inject along the jawline contour, you cannot inject deep in contact with the bone. You just need to inject here into this area. Right here into this area, you need to inject because you do not want to inject close to the facial artery and to the facial vein because they are connected and lying deep down. So it's kind of like you need to swim on the surface because as soon as you swim down, there is the shark and you do not want to get into this area. So this is why you just want to be up here into this area, very superficial, subdermal, and there you can position your product. How can you treat the marionette lines? Also straightforward. You do a cannula, 22 gauge, and you do subcision. You detach muscles and skin, which are very tight. You detach them, and in an area in this created space, you locate and position your filler material for a very nice and smooth area where you don't have the sharp boundary of the superficial fat compartments, which then stop at the labiomandibular sulcus and then continue into the perioral area. So they're kind of, as you can see, related on the anatomy. You can understand a lot of different structures, how they interact with each other and how they can guide you. So as you've seen in this lecture, the anatomy can really provide you with reasons why to inject in this way and not to inject in another way. It also can guide you the underlying anatomy to understand why you inject here, why you not inject into these areas. So this is very important to understand because anatomy has evolved from just being two-dimensional anatomy, has evolved to three-dimensional anatomy, has also evolved to functional anatomy in all of these respective structures, which is very, very important to understand how these structures work together. And with this, I would like to thank you very much for your attention. And I hope you enjoyed the lecture about the layers of the face. And as I'm stopped now to share my screen, I'm very confident that there will be a lot of moderators in the session together with you who can answer your questions. And if you still have questions, you can always reach me by my Instagram account or Facebook or email, whatever, and I would be most happy to answer your questions by any means. But I'm very confident everyone in this chat room now is very competent to answer all of your questions. And with this, I would like to thank you very much for attention. And I hope that at some point when this craziness is over, we can go back and continue with in-person lectures and with in-person meetings, right? Again, thank you very much for attending.